it's an old line, but I always tell my patients it's a marathon, not a sprint.
Yeah.
You can't finish speech therapy and like, I'm good. I did 6 weeks and I'm better. With aphasia, it's just, there's no way to tell.
It's a tough one for sure. The one thing I found kind of interesting is singing. Like songs like Happy Birthday, he will sing Happy Birthday. And ABCs, when he was in the hospital, he would do it. Some he won't really do it now, but Happy Birthday, he will sing a lot of it, and you can understand. That's
that principle where singing is sort of in a different part of the brain.
Yeah.
Right? And so that's why stutterers can sing without stuttering.
Welcome to Aging in Style, the podcast dedicated to celebrating aging and what it takes to do it well. I'm Lori Williams. I'm a certified senior advisor and senior housing expert. In each episode, you'll learn stories of older adults who are thriving in their 70s, 80s, 90s, and in some cases in their hundreds. Whether you're an older adult or the child of an older adult, this podcast is filled with insightful resources, organizations that are doing incredible work, and stories that will inspire you to volunteer, learn, and who knows, maybe even skydive in your golden years. Hi, welcome to Aging in Style. I am so glad you have tuned in today. Do you know what the word aphasia means? Have you even heard of it? Well, you are today. You are going to learn everything about aphasia, and we have the perfect guest to teach us about aphasia, explain what it is, how people end up with aphasia, and treatment for aphasia. So our guest today is speech-language pathologist Frances Gutierrez Burpo. And Frances is a certified speech-language pathologist with over 20 years of experience. She's worked in outpatient hospitals, inpatient rehab, and home health environments. She currently is a speech-language pathologist at Medical City, Louisville, and most of what she does there is she evaluates and treats people with swallowing disorders and speech and language deficits that are the result of strokes in most cases, or TBIs, also known as traumatic brain injuries, and other medical conditions. So I'm super excited to have her on and to help us all learn about aphasia, which is near and dear to me, unfortunately, as my husband does have aphasia due to the strokes he had 18 months ago. Gosh, that's flown by 18 months. Anyhow, welcome, Frances.
Thank you for having me.
Okay, so a lot of people have no idea what the word aphasia means, including myself. I didn't know until my husband was diagnosed with it. And actually, that's not true. Actually, Bruce Willis was the first time I heard about aphasia.
Mm-hmm. Yes. Yeah. There's a lot of celebrities out there that kind of have brought it into the forefront, like Randy Travis, Gabby Gifford. What's her name?
Yeah, that's it. Gabby Gifford.
Yeah. Uh-huh. There was Dick Clark. Glenn Campbell. Yeah, patients like that people were like, where did they go? What happened to them? And
it was aphasia.
It's aphasia, yeah.
Yeah, and with some, and we'll get into this, but I know Randy Travis had a stroke, but Bruce Willis, it was just, it's like a dementia, right?
Right. He has primary progressive aphasia, which is linked to like a more frontal lobe dementia. And so that's one of the hallmarks of that type of dementia is the aphasia.
Okay.
Yeah.
All right. Well, let's get into this because June is Aphasia Month, and I didn't know that until I saw it somewhere. It popped up, and I'm like, let's talk about aphasia. So what is aphasia?
So aphasia is an acquired neurological language disorder resulting from injury to typically the left side of the brain. It can be from stroke, head injury, tumor, lesion, anything like that. And it really affects the core elements of language. And it can hit primarily 4 areas, which is the spoken language. So that's kind of like the expressive piece. The receptive language, which is you understanding the words that I'm saying. And it can affect written expression and reading as well.
So, I mean, I'll just use as an example, my husband had 4 strokes. They were on the left side of his brain where the strokes hit, so it affected his right side.
Correct.
And he has expressive language issues. It's hard for him to write. He can read still. That's typically like with the stroke, that's what you see. And it just depends on like how much of the area was damaged or
exactly. It depends on how big the stroke was, exactly what is damaged. And, the language centers of the brain are close, but they're still a little bit far apart. So if you have a more of an expressive aphasia where you can't get words out, that's more that what they would call the Broca's area, that area of production. And then the Wernicke's area is more the comprehension of language. So you can say something to someone and they can kind of look at you because it doesn't make sense. Or you can show them a pencil and say that's a pencil and they'll be like, okay, that doesn't look like a pencil, you know. So it really depends on where. A lot of the times it can go across that, right? And do and have injury in both parts of those language centers. And that's where it gets really interesting. You have to get really creative with patients.
Yeah. And I know we don't have this so much anymore, but I know this was a struggle for us, is that he would think, I mean, it made sense to him, whatever he was saying.
Right.
Like, because I guess in their brain, it's like they're talking to you like they normally would. But what I'm hearing him say is not at all what he's saying.
Right, right.
And what causes that? That's just the expressive?
It's a little bit of receptive, but in expressive aphasia, they kind of process language a little bit slower, but when it's processed to them in their brain, it's correct. But the production is not. And so they'll say something, and a lot of the time they have insight into that, right? So they'll go, no, that's not what I wanted to say.
Yeah.
But sometimes they don't have insight into it, and they'll just keep saying the same word or whatever, like that is what I'm talking about. And it's you have to play a little bit of a game to figure out exactly what they're trying to get at. That's difficult, right? Because it's a word retrieval thing, and they can retrieve some words, but they're not necessarily the words that go with the objects. So that can be very frustrating for both the patient and the caregiver.
For sure.
Absolutely.
And we're going to talk more about aphasia and what kind of treatment, but I also want to define a couple of other words. So you have aphasia, and then I know when they were telling me everything with my husband, they're throwing aphasia, and then apraxia, which kind of sounds the same, but what is apraxia?
So apraxia of speech is a neurological speech disorder that reflects the impaired capacity that compromises the structures of the pathways of the brain. So what that means is that production, it's imitating mouth gestures, making sure that they can repeat a word. So it's more of a motor thing. So you can't cue someone phonemically usually, like say, okay, I want you to say da, da, da. They just can't posture their mouth that way because the brain is just not making that connection, that motor connection. So that's more a motor thing, and it goes hand in hand with apraxia a lot, which makes it difficult when you're trying to remediate with aphasia, when you're trying to remediate aphasia, because a lot of patients, you go through these cueing hierarchy, like what can I get from them stimulability wise? And so if you have phonemic cues and they have apraxia too, they're not going to be able to imitate that cue and probably come out with the word.
So they can't, their brain is not telling, say, their tongue to get in the proper position, or their lips, all the things that go into speech.
It's the motor programming of speech is not, there was a disconnect there.
Yeah. Okay. So when you have someone, and let's say, I'm going to say it's probably strokes, probably the number one.
Yes.
Yeah. Or traumatic brain injury, but that's usually it. So you have someone who's had a stroke, and then they come to you to begin therapy. And I know just from our case, like the sooner you can start therapy, the better, because you can start recreating those connections. So what kind of therapy do you do to help them?
Well, initially they come in and we'll do a full assessment. We typically do the Western Aphasia Battery, and that gives us a really good look at language all the way across. So it looks at expressive language, receptive language, it looks at reading, it looks at writing, and so we get a pretty good idea. After we kind of see what the deficits are, I always ask my patient, like, what's your goal? What are we looking to do here? Or the caregiver, if they can't tell me themselves what the goal is. And some really severe aphasics that don't have any words, we're just trying to get anything out, right? So I try to see what works for them. So like phonemic cueing, like I'm trying to get you to say dog, and I'll say duh, 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 say dog. Or carrier phrases, like having roses are red, seeing if that automatic speech comes out. Because a lot of aphasics will have like automatic phrases. And they can sort of stay stuck on those. It fools people, right? Because they'll be like, well, he said, good morning, how are you? And it's like, well, he's said that 2 million times.
Yeah.
And so that's something that he can come out with, and that's great. But any kind of new or any speech that they have to make up themselves can be quite difficult.
And it's so interesting you say that, because pretty early on when Mark was still in the hospital, I sneezed and he said, bless you. And I was like, oh my gosh. And I'm thinking, oh, it's going to be fine. But it's one of those things you've said a million times.
It's something that's very automatic. But, I also look and see what their strengths are. Reading. Can they read? Can they write? Sometimes patients' writing is a real strength. And so if they can't say the word, sometimes they can write the word. That's not how I want them to exist the rest of their life, but to decrease frustration with caregivers and, while we're doing therapy or whatever, that, carry a whiteboard and be able to do that, if you need to do that. It's difficult. I try to see how involved they are in the community, what they do for fun. And I try to tailor my therapy to that, knowing that, I've done wacky stuff that works. You just I've been doing this for over 20 years. So if I find something that works, that's what I'm going to go with. But the types of therapy can range from sensory trigger therapy, where the thought behind that is that we have a dormant part of the brain on the right side that's language based. And so using the left hand to write and make write words, alphabet, everything is trying to wake up that dormant part of the brain. I've done that some with patients, and I've seen it work. I don't know how much it carries over, right? Because I haven't done it really long term. But there's also like a therapy where we have sentences, right? That's a really good way to start with folks, especially when their writing is good, is looking at pictures and kind of describing what's happening in the pictures as they're writing it, and then being able to read it. There's lots of different types of therapy. You name it. We've tried it. I think that we aim at compensatory strategies for deficits, right? That aren't amiable to retrain, right? But if we aim at improving or restoring the impaired function, that's what we do first. When we see that that's not remediating, then we kind of really hit a lot of compensatory strategies. But you got to teach both at first, because we're not there yet, right? So
I know with my husband, they tried a communication board initially, and it was very simplistic. It was like food, like a hamburger and water for a drink and bathroom. And, I don't know how many people are against it, but I don't know if he thought it was too childish. He refused to use it. Do you have that happen sometimes?
Yes, we use that a lot in the hospital, especially to communicate with nursing staff. And you have to introduce it as, I know these are funny pictures. Yeah. And it looks really childlike, because it does. But I don't want you to have to go to the bathroom and you can't relay that. And then that's very frustrating. So you have to sell it a little bit, and they have to buy in, absolutely, to be able to use it. But I find it really helpful in the hospital, especially. Now, a lot of them are very busy. And so if you've got too many pictures on the page, that's distracting. It's hard to concentrate on so sometimes it's just as easy as, I will scale it back to yes, no. Yeah. Okay. And I'll just put a big yes and a big no on their tray table in plastic. And so nurses ask yes, no questions. They can say yes, no, and you have to make sure that reliability is there, right? Yeah. As you're testing the receptive.
That was my next question. So I know this is pretty common. I know it has been for my husband still. Sometimes he will say yes when he means no, and vice versa. So is that part of the aphasia as well?
It is. And it can become very automatic. But as it starts to remediate, people might come out with the yes, but then they'll go, and then they'll correct themselves. Okay. So sometimes you can't always take the first answer if you know it's not reliable. But we do ask questions like, is a horse larger than a dog? Will paper burn in fire? Those sorts of things to see if we get yes, no, correct. Are you a man? Or am I a woman? Are you a doctor? And it's interesting. If it's not consistent, you do have to be really, specific on what you're trying to talk about.
Yeah.
And sometimes even do some gestures. That's another thing we look at. If they can gesture, use things correctly, like toothbrushes. Show me how you brush your teeth. Show me how you comb your hair. That's all really promising, right? Because that shows that they know the action, they know what the word means, and that sort of thing. When you get people that can't necessarily do that, that can be more apraxia, and they can have apraxia in their limbs too. And so that's difficult sometimes when the comprehension is just not there.
Yeah.
But we can definitely work towards it. And I've seen patients that had no expressive deficits, but comprehension was terrible. And then they'd come out with jargon, right? All these unrelated words. And so that's where you have to kind of like, okay, we may have to use a communication board or augmentative communication, which I think they were pushing that a few years ago, like really pretty heavily, using iPads, using devices that talk for you or that you can point at. I think we've gotten away from that a little bit. But in very severe cases, I have gotten devices for patients that had maybe one word.
Did it just not work as well or something? Is that why you got away from it?
Everything else has to be sort of perfect. So you have to be able to like point and understand and
that's a lot.
Aphasia doesn't happen in a vacuum that way. And so you have to be able to motor plan and all of that. So it can be really difficult with patients that have other deficits.
Yeah. So it sounds like you look for whatever will work with that specific patient. So everyone is different, really.
Everybody's different. Yeah. Everybody's brain is different. Like, and the left side of the brain is pretty well organized. So if you look at an MRI report and you see there's a lesion here, then you can take a pretty good guess when you come in. But that's just the broad category, right?
Yeah.
Then you deal with the individual person and what's affecting them individually and what their lifestyle is and what their caregiver situation looks like and what, it's so many things. And you have to, it's a holistic approach. You can't just treat the aphasia. You have to look at everything.
And it's ongoing. It's not like a quick fix to it is what I've learned.
And there's not a quick fix to it. I mean, they do give you kind of those windows of recovery that are the best windows of recovery, which is true, 3 to 6 months and then up to a year. But we have studies that show past a year, there's still a lot of recovery to be made. It's just a lot slower.
Yeah.
And, we don't want anything to be slow. We want it to happen yesterday. So that can be difficult for the patients mostly. I mean, and the caregivers, but the patients don't, they're not patient. They want everything to happen yesterday. And it's like, it takes a lot of work. And, I have patients that will get all 3 disciplines, physical therapy, occupational therapy, and me. And they'll be like, this is the hardest one. Because you have to put so much concentration into it. And you're not using these big motor muscles, right? You're using your brain. So
it
definitely takes a while.
That's a lot. And I mean, the interesting thing is, it is, with the brain, you can create these new pathways and connections and things with therapy, consistent therapy.
Absolutely.
So that is the big thing to continue on. How, and you may not have an answer to this, I'm sure it varies depending on if people are Medicare or insurance, but how long do most people get therapy, get speech therapy?
It does vary. Medicare, as you probably know, has a cap, right? But if they're making progress and we can demonstrate progress, they're pretty good about going past the cap, right? Okay. A lot of patients have secondaries to Medicare now. And so whatever Medicare doesn't pick up, the secondary will pick it up. But I've seen some patients for 6 months, 8 months, and then I've seen some for 12 weeks. We always start out with let's look at 12 weeks out and let's see what we can do. We reassess in the outpatient setting. We reassess every 10 visits. And so then we can kind of get a look of, okay, this is better than last time. This is better than, and patients need that feedback too, right? Because they don't always see it. So it is important to give them that feedback and know that we're making progress. It's an old line, but I always tell my patients, it's a marathon, not a sprint. Yeah. You can't finish speech therapy and I'm good. I did 6 weeks and I'm better. With aphasia, it's just, there's no way to tell.
It's a tough one for sure. The one thing I found kind of interesting is singing. Like songs like Happy Birthday, he will sing Happy Birthday.
Yes.
And ABCs, when he was in the hospital, he would do it. Some he won't really do it now, but Happy Birthday, he will sing a lot of it, and you can understand.
That's that principle where singing is sort of in a different part of the brain.
Yeah.
Right? And so that's why stutterers can sing without stuttering.
Oh, yeah.
Right? And so those automatic things like months, days of the week, ABCs, 1, 2, 3s, those are important to do, because sometimes when you're in therapy and it's like brick wall, brick wall, brick wall, okay, let's do this, because they've got to have some success to not sort of give up.
Yeah.
And so that comes in handy a lot when they can do that, because I think it's really important. And also math. We don't think about math as being affected because it's a language disorder, but a lot of patients do have a math component where they can't read a clock. They don't understand what the numbers are. And that's always interesting, because if the math's affected, sometimes their language, their writing and reading is pretty good, but it's the math that's affected. Yeah. So it's interesting when we test all of that and what we see. We do like what colors are, what shapes are, all of that. And a lot of it can seem very juvenile, but that's just the way we go about it.
Yeah. I know now he is in rehab, just a everyday rehab. It's a brain rehab, which is interesting. Like, you get speech, by the way, in the hospital. When you go to, in hospital rehab, in outpatient rehab, there's speech that follows you in all of these different locations,
Absolutely.
Which is wonderful. But where he is now, I go every month and sit with each therapist, and the speech therapist will show me. They do a lot on the iPad, and she'll show me, like, he got an 82% here, so we upped it here, and now, she'll show me kind of like the trends of where it's going, which I find very interesting. So do you use a lot of that kind of technology?
I use my iPad sometimes. I don't use it to kind of, we don't have those resources where I am as far as being able to use that. But I'll take my personal iPad in, and I do have certain language apps and that sort of thing that I'll do with them. As the generation, as the baby boomers are aging and everything, and they're more into technology, so that's going to be more of a staple for us to use technology instead of, just flipping cards with pictures on them, because that's not how this society operates anymore.
Yeah, generations changing for sure. The other thing, and I think it is good, and I hadn't, of course, thought about any of this before, but I know that they will have my husband and like a few other people, they have them sit and like play a game together, because it gets you, I guess, what is it? Just trying to get that conversation going with
it's to have a different communication partner, right? And so be able to be in a situation that you wouldn't necessarily, you can keep yourself out of in the normal, right? At home, like, you want to paint? No, I'm not going to play a game. But if the therapist makes you do it, you have to do it, and you have to communicate with that person. So I'll take my patients sometimes down to the cafeteria or to the gift shop to go buy something and interact with other people on the way, just to see how they do in the community, because they get very attached to their caregivers and they think, well, I don't have to communicate. But you should start to communicate instead of looking at your caregiver and they're going to tell you what I want.
Exactly. So, I think that's really interesting that they do that. I think it's great for him, because if I say, let's play cards, he'll be like, no.
Yeah.
But I've noticed they've started like once a week, they take them for coffee. And same thing. I don't know if he orders or, what he does. I mean, they may point to something. I don't know. But I think the same kind of concept where you're out in the community and you're not relying on someone. I think that's great.
Well, and you can't really predict what someone else's reaction will be to you, right? So I think that's the uncertainty, and that makes the anxiety go higher, which can make the aphasia a little worse. There's all of these other factors. But all you can do is try. And I feel like most people will be like, oh, okay, they're trying to tell me something, and we'll just really listen intently. But what happens is the communication partner, they get stressed out too, because they want to fill in for you. And there's that burden of communication where it's like, oh no, what do I do? So it becomes a high anxiety situation. Yeah. So if the patient gets used to doing it, it lowers their anxiety more. Now, the communication partner might still be like, oh no, but that's okay, because you're just trying to get what you're trying to get out.
Exactly.
And I think most people will kind of okay, give you a minute to see if you can get it out.
Yeah, I think that's true. So for the caregiver of someone who has aphasia, what are some tips that you would give them? I
always tell the caregivers, don't overburden them at home with tasks, right? Because we're going to be doing therapy. And if you want, I always say, if you want to go to the dollar store and get picture cards, playing cards, number cards, whatever, and do that, that's great. But don't make it a whole day thing. Like, we're going to do this for 2 hours because they're going to shut down and not do it. So say, like, let's do this for 10 minutes and then practice it for 10 minutes. I feel that caregivers don't want them to struggle. Obviously, we don't want our loved ones to struggle when they're trying to communicate. So we want to fill in what they're trying to say. And sometimes that brings the anxiety much higher because it's like, no, that's not what I'm trying to say. So I give them strategies like, if they can write, give them a pen and pencil or a paper so they can write what they're trying to say. If they can gesture, have them gesture. But caregivers need to kind of let them make their way communicating a little bit. Because if not, they get really reliant on their caregiver and they don't try to communicate.
Or very frustrated with their caregiver.
Which I think is just normal, right?
It is, absolutely.
It's very normal. And I've had patients that say, like, I got in the biggest fight with my husband because we were trying to communicate and that just, both of them were upset and they got, and so in that case, I'm like, take a breather.
Exactly.
Take 10 minutes and pray, meditate, whatever you do, get yourself centered and get back to trying to communicate what you need to.
Yeah.
But going round and round in that is only like making your blood pressure go up, making you really agitated, and it's just not.
It's upsetting both of you. And, it's funny, my son, actually, I learned from him because he is just a super chill dude.
Yeah.
And he's a guy. Okay. So women, we do take things a little more personally.
Sure.
So when my husband is having a hard time communicating, he's getting frustrated and kind of raising his voice, Chris will just say either okie dokie or I see, and then he just removes himself from the situation. And so I watched him do that, and it just diffused it like that. And I'm like, he is such a genius. And he's a guy, because guys don't take it. He's like, fine, go and do his own thing, where I was just like, taking it personally. So now, when that happens, I just say, okay. And I go in the garage, or I just go somewhere else, just remove myself from the situation, because it is frustrating for him. I get that.
And it gives the patient a minute to kind of,
take a breath,
refocus and see what they want to say. And it gives you a minute to take a breather.
Just let it go and just be like, it's not personal.
I mean, think about it. If you could not communicate what you wanted to say,
I can't imagine.
That is really terrible. And so
it is.
I have so much compassion for these patients because I'm a talker. I mean, I'm a speech pathologist. That's what we do for a living. And so if I couldn't express my needs, my wants, my ideas, that would be really tragic. So I try to validate that because I think that's lost a little bit in how we do stroke rehab. Not as therapists, because I think as therapists, we embrace that. Physicians, maybe not as much sometimes because, they're very based on the, evidence-based, and this is what we do. We're evidence-based as well, but we have to look at the whole patient and what their situation is. So I feel validating that it stinks and it's not going to be easy and it's going to be a rough road. I always tell my patients, you can sit on your pity pot for 10 minutes a day.
Yeah.
And then you got to keep moving. So set a timer if you're going to be mad and cry and curse or whatever. Do that for 10 minutes and then find something else to do or something else to think about.
Yeah.
Because you've got to have the energy to continue and go forward, or what's your alternative?
Yeah, exactly. So what do you see with recovery? Because, I mean, I feel like probably with aphasia, depending on how severe it is, you only get to a certain point. I mean, do most people, or I guess it just depends on what level their aphasia is?
Yeah, it depends on what we talked about before, like the size of the lesion and how impaired they were and, other impairments that they might have as well. But I mean, I've seen patients make a pretty darn full recovery, right? when you look at the age of the patient, being able to have a young brain, if you had a stroke at a young age, then that's, or a traumatic brain injury, you see those patients obviously do better. They just kind of have more plasticity to their brain than we do as we age. But I have seen, pretty decent recoveries with patients. It's always sad when you kind of get to a plateau and you're not moving past it, right? Because there are plateaus, but then it picks up again. And that's always difficult for me to kind of break up with a patient that way, because it's like we're not making a whole lot of progress. So a lot of the time we'll say, let's take a month off and see if there's any backsliding, right? And then, I talk to the caregiver, I talk to the patient, but that is difficult. I don't like to have those conversations.
Yeah,
I like to, have the positive conversations, but I have seen a lot, but it's hard for the patient to see, because patients will be like, oh, am I ever going to get my words back? Am I ever going to, I'm like, well, you just said that whole sentence. You know what I mean? Like, I heard you having a conversation in the waiting room with another patient. So they don't always get it, but I don't discount that, right? Because they don't feel like they did before the stroke. And that is completely valid.
Exactly.
But I also don't want them to miss the forest for the trees. Like, this is, overall, you're communicating so much better than you were when you first saw me.
Yeah.
So we've got to, see that and be proud of that. And there's still work to do, but they can get in kind of that spiral of, oh, this is never going to be the same.
Yeah. Do you have some who they don't even want to talk? They don't even try?
Yes.
Okay.
Yeah.
Yeah. I mean, happy with my husband that he will try. I don't know a lot of times what he's saying, but I mean, he's having a conversation and talking to me, and I'm picking up usually by his gestures kind of what he's saying to me. So I'm happy that he tries, but I know that there are some who just don't even try.
Yeah, and you're probably the Mark whisperer, right? So you kind of know what he's trying to say. But there's some that I've come in and they just are really refusing to do anything for me, or they get so frustrated that they're just not.
They won't even try. Yeah.
That's thankfully few and far between.
Good.
But when it's really severe and they have 0 words, that's difficult, because you're trying to grasp for anything that shows promise for them. Yeah. And it may take longer than they care to. So they're like, why am I doing this? This is pointless.
Yeah.
So it does, that's hard when you have patients like that. And it's hard on the caregiver because they don't want to go to therapy.
Yeah.
Like, I don't want to go. I don't want to go. And it is tough.
Yeah. Is there anything like in research, and I know it's because it's the brain, but is there any kind of research coming? Is there any kind of like medication that might help make it better? I mean, we always look for the easy way, but when it comes to the brain, it doesn't seem like there is any kind of easy, quick fix.
Not really. I mean, other than trying to prevent a stroke to begin with, right? So, managing your blood pressure, making sure you're getting your checkups, having, if you have any symptoms of anything that could be the beginnings of some sort of neurological process, to go and get it checked out. That's the only way, really, because, the brain's a brain, and there's only so much protective stuff we can do for it. And those language centers are what they are. So if you have a stroke and they get damaged, unfortunately, but I think that, the number one cause of stroke is uncontrolled blood pressure. And so that's the biggest thing is monitor your blood pressure, take your medication. Monitor your cholesterol, do all the things that you're supposed to do. And that's sort of part of my therapy as well, because a lot of patients will have that fear of, I'm going to have another stroke. When is the next stroke going to happen? And it's going to be worse, or it's going to be. And so I try to tell them, like, the only thing you can do is do everything you can to prevent it. And I can't tell you you're not going to have another stroke. That's just, I can't tell you that. But if you're doing everything you can, then that's all you can do. And you have to kind of be happy with that.
Yeah. We had a podcast, I guess, a few weeks ago where we had from Medical City, Louisville, that came on and talked about strokes. And 80% of strokes can be prevented. Yes. And that's huge. And it makes me sad that this wasn't prevented for my husband, but that is, I mean, my message now is to get this information out there to people, because I see what it looks like, and it's not pretty.
Well, and I feel part of my role too is stroke education, right? Because they'll depending on how much education they got in acute care and if they went to inpatient rehab and all of that. I've had patients before that have come in and said, no one talked to me about anything, and so I feel like, why did this happen to me? They have no idea.
Yeah.
And so I feel that that's part of my role too. So I do a lot of education with my patients. I love a colorful handout, as my colleagues will tell you. They're like, the trees are dying. I'm like, I know, but it's so pretty. And so I really do. Education is really, really high for me, because I think that you have to know what's happening to be accountable for how you go forward with your recovery and, with preventing other strokes. You have to be responsible for your recovery.
And I hadn't thought about that some people don't know why it happened. And, especially if you don't have an advocate, or you're older maybe, and there's no one to really ask those questions. I mean, I was just, in the doctor's face, I'm sure he was like, please just go away. I'm like, why? Show me why. Show me. I mean, I need to know everything. So I knew and could tell Mark, this is what happened.
Right. Well, and I always feel like as we get older, it's always good to take somebody with you to the doctor, to have 100%. 2 sets of ears, right? So you can hear what they're saying. I also feel like people may manage their blood pressure, but then they have so much stress in their lives. Work, they're working 18 hours a day. They're drinking too much, or they're eating things that are unhealthy. And they may say, like, I never had high blood pressure before, but then you take all those into account. It's like, well, you came into the ER with 200 over 150. Yeah. That's really high. And so they've got to be aware that lifestyle makes a difference. I always tell families, like, try not to upset them, because that just brings up their blood pressure.
Exactly.
And, it puts them at risk for another stroke.
And then I think also, as a caregiver, and I'll speak for caregivers, is, everyone tells us take care of yourself. And it's hard to take care of yourself as 100%. A caregiver. And you kind of live, I just said this to a friend, I sort of live in that fight or flight kind of, like, always. And that's not good.
Right. No.
So, I mean, you have to, as hard as it is, and sometimes it is like I get all his doctor's appointments, we make it. But anytime I have a doctor's appointment, and you need to keep all your doctor's appointments if you're a caregiver, sometimes it's going to look like you are fighting to get to the doctor. And this just happened to me. We had that bad storm. I had no power. Mark didn't go to rehab. I'm like trying to get past all this. And I'm like, I will make it to the doctor. It was one thing after another, even to the point I go to back out of my driveway, and this truck had blocked my entire driveway. He was trimming a tree or something. No. I went out there. I'm sure he was so scared. I was not nice. I'm like, move it now. So he moved it, and I made it to the doctor. But it's kind of like that. Like, as a caregiver, it's like, can something just be easy? But go to the doctor, get all your things checked.
Because what good are you to them if something happens to you? I say that a lot. It's, something happens to you, you have a stroke, or you get COVID, or you end up with pneumonia, and then do you have a backup caregiver? Most of the time you don't. No. It's really difficult to have that. But I think you're right. The caregiver and the patients are in this PTSD sort of state where this very traumatic thing happened, and they never expected it to happen. It's not like they ever talked about it happening. Yeah. And now you're just sort of trying to keep all the plates in the air. But you have to take care of yourself, or you're no good to them.
Exactly. So the best thing you can do, I mean, I hope that this has been enlightening. People know what the word aphasia means now, because, like we said, not many people know it. I didn't know it until I had to know what it means. But the number one thing is, we don't want you to have aphasia. And so prevent a stroke.
That's right.
That's the big tip here.
100%. We don't want you to have a stroke. We don't wear your helmet when you're riding your bike or your motorcycle. We don't want you to have a head injury. All of those things. At the first sign of anything that you might think is wrong, go, because you never know.
Yeah, absolutely. Good advice. Well, thank you so much for being on the podcast and educating us on all things about aphasia and apraxia. And it's so interesting how the brain works. And, I think it's good information for people to have.
Well, thank you for having me. It's been a pleasure because a brain nerd like me, I mean, this is big. So thank you so much. I appreciate you inviting me.
You're welcome. You're welcome. I know I know the word neuroplasticity now, and I love saying it because I sound so smart.
I love all the big words I get to use.
Yeah, right. Well, thank you so much. And thanks for listening, guys. Please share this with your friends and family. And to learn more, please visit my website, which is loriwilliams-seniorservices.com. And we'll talk to you next week. Bye-bye.